Hi, this is Dr. Jennifer Perry with Cape Fear Eye Associates. Thanks so much for joining me this evening to discuss diabetic eye disease. But before we get into the topic at hand, let's discuss our eye team at Cape Fear Eye Associates. We've got our vitreoretinal surgeon, Dr. Nithin Nagam, our pediatric specialist, Dr. Leah Bonaparte, our comprehensive ophthalmologist, Dr. Wayne Riggins. You've got myself, your host for tonight, Dr. Jennifer Perry. I'm also a comprehensive ophthalmologist. And last but not least, we've got our corneal specialist, Dr. Sheil Patel. Together, we've got you completely covered. So, tonight we're going to discuss vision loss in the eye, specifically diabetic retinopathy. But what are the top causes of vision loss in the aging eye? Number 1, we've got cataracts. Number 2, we've got glaucoma. Number 3, we've got age-related macular degeneration. And coming in at number 4, we've got diabetic retinopathy, which is the number 1 cause of vision loss in middle-aged Americans. Don't worry, we're going to touch on cataracts, glaucoma, and age-related macular degeneration at the end of the presentation. So how significant is this problem of diabetes? Well, 34.2 million Americans have diabetes. That's about 10% of our population. And approximately 1/3 of those are not yet diagnosed. Diabetes can be broken up into type 1 and type 2. Type 1, also known as childhood onset, is when the pancreas is insufficient at making insulin, which helps us digest our food. Those individuals present early and they present very ill. And because of that, because we know when they develop the problem of diabetes, they don't need an eye exam until approximately 5 years after diagnosis. On the other hand, type 2 diabetics, the one we're most commonly aware of, our adult onset diabetes, occurs later on in life, and you produce insulin properly, but your body's just not very sensitive to the insulin that's produced. Those individuals can walk around not knowing that they have diabetes, and because of that, it's recommended that they have a full dilated eye exam at the time of their diagnosis. 1 out of 5 of those individuals newly diagnosed with type 2 diabetes are going to have retinopathy or retinal problems related to diabetes at the time of their diagnosis. So what increases our risk of developing diabetic retinopathy? Well, the longer duration that you have the diabetes, so somebody who's newly diagnosed versus a person who's had it for 20 years. If you've had it for 20 years, you're more likely to have problems. And also higher and more erratic blood sugars. So individuals who have a significant swing in their blood sugar, such as one day the blood sugar is in the 80s, the next day it's in the 400s, or somebody who's getting on the right track, bringing down their A1C from, say, an 11 to an 8, but they do it so rapidly that the body can't keep up. Because of that erratic blood sugar, they're more likely to develop diabetes in the back of the eye. Why is this important? Why is an eye exam so important? Well, as they say, the eye is the key to the soul. Based off your eye exam and those findings, I can also diagnose coexisting nephropathy, which is kidney disease, coexisting neuropathy, which is peripheral nerve disease, or cardiovascular disease involving the heart. Before we go any further, let's go over some basic eye anatomy. Starting at the front, going to the back of the eye, we've got the cornea right here. This is Dr. Patel's specialty. This is kind of like the window to the eye. This is the thing that hurts like the dickens if it gets scratched. It's also something that if it gets scarred for whatever reason, you can't see through it and you have to have a corneal transplant. Behind the cornea, we have a space filled with fluid called the anterior chamber. This plays a significant role for glaucoma, which again we're going to talk about at the end of the presentation. Not well visualized here, but there's a muscle here called the iris, and myself it's brown, and you it might be blue, hazel, or green. This is a muscle that contracts and releases to control how much light gets into the eye. So for instance, in a room that's dimly lit, we want more light in the eye. The iris enlarges itself to allow more light in. And then in a very well lit, say you're outside, it contracts to allow less light in the eye. Behind that would be the lens of the eye. This is the thing that people get cataracts in. And then this entire large space here is filled with vitreous. The vitreous is important because it helps plaster the retina against its blood supply. The vitreous is also important because this is where those pesky floaters that all of us have occur, in the vitreous of the eye. And then back here is where the optic nerve and the retina lie. To focus on those structures a little bit more, so we've got our optic nerve, with the blood vessels coming out. And then here is the macula. The macula is extremely important in our retina because this is the center of the retina that allows us to do our reading, our driving, our fine vision. So when we go through our images throughout the rest of the presentation, we're going to go from vitreous, optic nerve, blood vessels, and macula. So there are two forms of diabetic retinopathy. The first would be non-proliferative diabetic retinopathy. It's the more common and less severe of the two types. It involves small blood vessels in the retina that quote-unquote become leaky. Blood and fatty tissue, otherwise known as lipid, deposit in the retina where they're not supposed to be, and because they're leaking out of the blood vessel is not getting blood to where it needs to be. I think of the analogy of me trying to water my plant with the water hose. I need the water hose to function to get water from point A to point B to water my plant. In diabetic retinopathy, there's problems with the water hose, as in micro holes in it, and water leaks out along the way. And then less water is getting to my plant where I need it to be. Same concept with non-proliferative diabetic retinopathy. Let's look at some examples. So our vitreous is clear. We have a clear view. We've got our optic nerve, we've got the blood vessels, and along the blood vessels you see these red spots consistent with leakage of the blood out of the blood vessel. Because the blood is leaking out of the blood vessel, blood is not getting to the far periphery of the retina where it needs to be. In addition to blood leaking out of the blood vessel, we also have hard exudate, otherwise known as cholesterol or lipid, leaking out of the blood vessel. And this is very close to the macula, but not quite involving it. This individual has significantly worse non-proliferative diabetic retinopathy. We have a clear view, so the vitreous is clear. We've got our optic nerve. The blood vessels have significant leakage of blood all along here, and then also significant leakage of the lipid from the blood vessels. And this individual has leakage of both blood and lipid near and within their macula. That is significant, and that is called macular edema. The second type of retinopathy is the proliferative type. It's the worst of the two in its potential for significant, devastating vision loss. What ends up happening is because you don't have the blood getting from point A to point B like you need it, the eye says, hey, I'm all the way out here and I'm not getting enough blood. Please grow new blood vessels, ones that are not intended to be there, ones that are leaking, that easily rupture, so that I can get blood. But again, they're not healthy blood vessels. So you have this fragile blood vessels that grow and they might burst, filling the eye with blood, or they can grab onto another part of the retina and pull on it, causing a retinal detachment. So for instance, in this picture, we've got a clear media, our vitreous is clear, but notice these are the normal blood vessels, but these little tiny ones right here are not supposed to be there. So this person has neovascularization of their optic nerve consistent with proliferative diabetic retinopathy. This individual has the same thing, and you can see more of a bleeding aspect happening here. So clear, the vitreous is actually a little bit hazy. You've got your optic nerve, and coming off the superior aspect of the optic nerve, there's blood, because that blood vessel is not supposed to be there. It's leaky and fragile. If that blood vessel were to burst, we would get what's called vitreous hemorrhage. So this, because you can't see the blood vessels and because it's a hazy picture, we know that this blood is in the vitreous, in the jelly in front of the retina. This person has bled, and then underneath it, I can't see the blood vessels or the optic nerve because the blood is covering it. You can imagine this individual can't see through blood, and their vision has significantly dropped. And even getting worse would be an individual who just has neglected their vision. This person, we can't even tell where their optic nerve is. Their vitreous seems to have blood in it because you can't see the retina behind it. And also you have these little white areas, and that's traction from those blood vessels pulling on the retina. This person has a tractional retinal detachment. Unfortunately, the chances of visual recovery in this individual are slim to none. Something that can happen both with non-proliferative and proliferative diabetic retinopathy is macular edema, and I briefly touched on this earlier. When the lipid in the blood leak out of the blood vessels into the macula, into your center vision that you use for driving and writing and fine vision, it is called macular edema. This individual also has significantly decrease in vision, And it's equated to kind of looking underwater while you're swimming, where you can make things out, but that fine vision is gone because cholesterol has leaked into their center vision. Again, that's called macular edema. So, how do we treat this? Well, the biggest form of treatment is prevention. We'd love to not ever have or see any of this in the back of the eye. The way that we can best prevent this would be following an American Diabetes Association diet. We want to exercise. We want to vigilantly monitor our blood sugars. And unfortunately, that does include frequent sticks to the fingers. Check the blood sugars in the morning and throughout the day. We want to be compliant with all medications that are prescribed by our physicians, and then do regular follow-up with all of our physicians, whether that be the eye doctor, the primary care doctor, or your endocrinologist. But if, unfortunately, we do start to notice some changes in the back of the eye related to diabetic retinopathy, treatments include laser surgery, injections in the eye, and intraocular surgery. So there are two different lasers that we can do to treat. The first would be called focal laser, and it's used to treat the macular edema we just discussed. What we want to do is use a very light laser to barricade the cholesterol from leaking into the macula. So this individual on the picture on the left, they've got cholesterol leakage all around their macula. We want to take a laser and barricade, basically forming scar tissue to keep out the cholesterol leaking from the center vision into the macula. This is what this individual will look like after that laser. And as you can see, because most of the cholesterol is over here, we put the laser in between their macula and the cholesterol to, again, prevent cholesterol from leaking into the center vision. This laser is not painful, but it's very important that you stay still, because if we accidentally laser your macula or your center vision, that can lead to permanent blindness. The second laser is not a fun one. It's called panretinal photocoagulation, aka PRP. And what we want to do is we kind of want to kill off the rest of the retina to save the central vision. So, starting with the picture on the left, we've got a person who is starting to bleed from diabetes along their inferior blood vessels in this eye. Again, the body's sending out a signal stating, hey, we've got blood leakage and I'm not getting enough blood, so grow new blood vessels. Well, what this laser does is it, quote unquote, kills off the part of the retina that's sending out that signal saying grow new blood vessels to save the center vision, the main blood vessels, and the macula here. So what we do is we take a laser and we put 1,000 burns in the back of the eye, again, to kill off the peripheral retina to save the center vision. This laser is not comfortable at all. And oftentimes people have to come in 2 or 3 times in order to get all 1,000 spots into the back of the eye. This laser is also not without possible side effects, including diminish of your color vision and also loss of your peripheral vision. In individuals who have macular edema and or proliferative diabetic retinopathy, medicine has shown us that actually giving a medication in the eye is also beneficial. Some of you might have heard of the intravitreal injections called Avastin, Lucentis, or Eylea. This is a medication that, yes, we inject directly into the eye, and magically it reverses the signs of diabetes, both the macular edema and the proliferative diabetic retinopathy in the eye. These medications work very well, but they only last for about 8 to 12 weeks at maximum. So these individuals are frequently in our office getting these injections in the eye. And as horrible as it sounds, people tolerate the injections in the eye better than they do the PRP. And also, the injections, again, reverse the signs of the diabetes in the eye, so they're long-term better with less side effects. But of course, anytime we stick a needle anywhere in the body, there's a risk of infection, so we're very cautious about cleaning the eye before we do it. And also, we are really, really good at numbing the eye, so you don't feel any pain such as a needle, but you do feel a little bit of pressure because we're putting medicine in the eye. It sounds horrible, but we do it every day. And last but not least, hopefully no one ever gets to this point, is surgical intervention. So in those individuals with really bad proliferative diabetic retinopathy, whether they have a vitreous hemorrhage as shown in the picture above, or they have a tractional retinal detachment, which we displayed earlier, those individuals would need Dr. Nagam to go into the eye in the operating room and suck out the vitreous with the blood in it. He would also try and release any traction that's occurred and also put in laser at the same time if necessary. Unfortunately, most of the time, once you get this far in your diabetes, it's very hard to regain vision, and certainly most of these individuals do not regain 20/20 vision. So, once you have diabetes in the eye, you do have an increased risk of developing glaucoma and cataracts. Glaucoma tends to coexist with diabetics about at an increased rate of 1.5 incidents. And unfortunately, it's not something that presents itself with obvious symptoms. So oftentimes you need the eye exam in order to diagnose the glaucoma. Cataracts are something that all of us are going to get, but diabetics are more likely to get it earlier and more severe. So as opposed to having a cataract that needs removal in your 70s or 80s, you're more likely to get it in your 50s and your 60s. So that's my spiel on diabetic retinopathy. Before we conclude this presentation, I wanted to just touch on some other common causes of vision loss in the aging eye, including cataracts, glaucoma, and macular degeneration. So going back to our eye anatomy, we're going to go from the front part of the eye to the back. The lens of the eye is where people form cataracts. When we're born with a crystal clear lens, such as here. As we get older, at no fault of our own, that lens starts to turn gradually more yellow, preventing light from getting in the eye. And as I just mentioned, diabetics are more likely to develop this cataract at a younger age. Well, if you're not getting as much light into the eye, then your vision is going to gradually decrease. And oftentimes, individuals don't even realize their vision's decrease unless it's more affects one eye than the other. But when I test your vision, I can say, hey, 20/40 is required or better is required in order to pass your driver's test. If you are not seeing 20/40 or better, then we need to do something about the cataract. Or if you drive at night and you are starting to notice halos around the car lights or the lights when you're driving at night, that's also an indication that the cataract's gotten worse. So this does require surgery in the operating room, in which we lay you flat, we give you medicine to relax you, and we go into the eye. We divide the cataract into 4 pieces, suck out all 4 pieces while keeping the clear hammock intact that holds everything to the top of the eye, and then we put a clear artificial lens in that hammock. That hammock holds it there for the rest of your life. Surgery is done, should not have to be repeated. Cataract surgery is the most common performed surgery throughout the United States, and it's very successful. My favorite thing about being an eye doctor is that after doing one eye, somebody comes in the following day and they've noticed that the trees are brighter, the colors are brighter, their vision's more crisp, and they sit there and tell me, oh, I didn't realize my vision was that bad. And it's unfortunate that it takes doing one eye before they realize it, but people are so happy after this surgery. Going back to our eye anatomy, we're now going to talk about glaucoma. That involves the anterior chamber, this space right here that's filled with fluid, and the optic nerve back here. Every time you come see us at an eye doctor, we check your vision and your pressure, and we look at your optic nerve. What happens in glaucoma is the pressure in the anterior chamber here is too high. Average pressure is a 16. Oftentimes in persons with glaucoma, they have 18 or higher. That pressure is too high for the eye to handle. It squeezes the optic nerve and it loses some of its cells. That optic nerve is important and it needs all of its cells because that's what carries the information from our eye to our brain so that we can see and interpret our world. So when I look in the back of the eye, I'm looking at the optic nerve and I'm judging a cup to disc. This larger area is the disc, the optic nerve, and there's a cup that's indicated by a little bit of yellowing right here. So I'd say this individual has a cup to disc of a 0.3. 0.1, 0.2, 0.3, 0.4 cup to disc are all normal. When I start saying 0.5 or above, things are abnormal. So this individual right here, you can see their disc here and their cup is significantly larger than the person in the picture on the left. And because of that, their cup to disc I would judge at a 0.7. So they've lost some of their orange healthy pink tissue that communicates to the brain. This individual in the third picture has lost almost all of their orange healthy pink tissue for a cup to disc of a 1.0. And the way that that's significant is as you lose that orange healthy pink tissue, you start to lose your peripheral vision. So here you have a normal picture. Here you're starting to get hazy around the edges. And eventually, once you've lost all your orange healthy pink tissue of the optic nerve, it's like you're looking through a Cheerio. Glaucoma tends to be painless and it's progressive and so slow that people don't notice it's happening. So it can be diagnosed in its very late stages, and by that time, it's hard to reverse the vision. The way that we treat glaucoma is with eye drops. This is the standard form. We've got 5 different eye drops. The biggest thing about eye drops is that it puts the onus on you in order to get that drop in every day to keep that pressure down. Next would be laser surgery, which is done in the office. We focus on the drainage angle of the eye, which appears like a sponge, and the laser puts more holes in the sponge so that more fluid can leave the eye. The laser is called a selective laser trabeculoplasty, and it works in about 7 out of 10 individuals. Typically, if I can see the drainage angle of your eye, then I can properly laser it, and it's successful. We oftentimes do this in conjunction with eye drop, so instead of adding a second or third eye drop, we will then try the laser. And last but not least would be surgery. In individuals who either can't get the eye drops in or have failed success with eye drops and or laser, we move on to surgery and we escalate as needed. Here would be what's called the cahook, in which I take out the sponge so that the fluid has a direct pathway to exit the eye. If you need more, there's a tiny drain that we can put in the eye that gives direct access from inside the eye out on under the conjunctiva so that fluid leaves on top of the eye. And last but not least, in very severe cases of glaucoma, we put a tube shunt in the eye where this hardware here makes sure that there's no scarring. Fluid can leave the anterior chamber and drain directly into this hardware, and it makes sure that there's a constant outflow pathway. Oftentimes, when there's a cataract in addition to somebody who's got glaucoma, even if they're kind of successfully controlling the pressure at that time with the drops or the laser, I will offer to simultaneously do a glaucoma procedure while they're already in the operating room to hopefully decrease the need for additional drops or additional surgery down the line. And then last but not least, we'll talk about macular degeneration, which is in the back of the eye, again involving the retina. So we've got our retina with our optic nerve, our blood vessels, and macular degeneration involves the macula. So in macular degeneration, this is something that's passed down from your parents. It tends to affect Caucasians more than African Americans. And what happens is the retinal layers that are responsible for excreting waste products from the macula, they get overwhelmed and the waste products tend to build up. And that's what you see here in this first picture, these little white spots. These are identified as drusen, and I tend to refer to them as age spots. Those age spots weaken the structural composition of the retina, and if it gets too bad, it can lead to bleeding and scarring in the eye, which is shown in the second picture here. So this person has their age spots out here, their drusen out here, and then it's weakened the structural capabilities of the macula, and a blood vessel has broken through and bled here and then formed a scar here. This individual has dry macular degeneration. This individual has wet macular degeneration. One scan that we get when you come into the eye doctor would be an optical coherence tomography, an OCT, and this helps us further look at that macula. This picture here shows a perfect macula in which we have a nice dip in the center. This is what's used for our perfect fine vision to drive and to read. And these different shades of gray are the different layers of the retina. Here, this little white line here is the part that's supposed to get rid of any waste created by the retina. That is what becomes overwhelmed in macular degeneration. It starts to fail. So in dry macular degeneration, we've got buildup of those waste products here, and that's what these lumps and bumps are. When somebody reverts to the wet macular degeneration, a blood vessel breaks through these age spots and forms bleeding spots, which are indicated by these black spaces here, and then this is scar tissue. Macular degeneration, unfortunately, is not something you can exactly prevent because, again, it's inherited. But the best ways to try and slow the progression would be not to smoke, to stay hydrated with plenty of water, use UV protective glasses, monitor your vision with an Amsler grid if and when you are diagnosed, and take the AREDS 2 PreserVision vitamin, which is sold over the counter. The same medications that you treat the macular edema and diabetes, you can also treat wet macular degeneration with injections in the eyes. So those individuals are also frequently in our office getting injections in the eyes. Thank you so much for your time and attention. Please come visit us. We'd be more than happy to address any eye issues that you have. We're located at 1726 Metro Medical Drive in Fayetteville, North Carolina, or you can call us at 910-484-2284, or you can visit our website at capefaireye.com. Thank you so much and have a great evening.